Centralized Utilization Management Caseholder Training. Today's topics are: what is utilization management? Who is on the UM team? What does centralization of UM mean to me? What will UM be looking for to support medical necessity? How can UM staff provide support to me? What does UM have that they can share? Utilization management is a set of administrative functions that assure appropriate clinical service delivery. UM is the evaluation of the medical necessity of services requested and provided to consumers for the purpose of controlling costs, monitoring the quality of care, and ensuring efficiencies under the provision of the Medicaid Provider Manual. UM works to ensure services are medically necessary, delivered at an appropriate level of care, and that services are consistent with criteria and clinical practice guidelines. UM works to continually assess and identify areas of improvement to consumer access to care, as well as quality of care available to consumers. The role of utilization management is to identify, monitor, evaluate, and resolve issues that result from an inefficient delivery of service. We know that the reality is there is not enough funding for every person we serve to have all of the services they desire. So we need to think differently and creatively to allow for everyone to reach their goals and meet their needs with a limited number of services and supports. The services we provide must be spread equitably across our consumers and across our service areas. Who's on the UM team? Nicole Menace, and Nicola will be the main contact for Midland County. Angelia Richard, and Angelia will be the main contact for Clare Gladwin counties. Rochelle Ozarzak, and Rochelle will be the main contact for Macasa Osceola counties. Katie Kring, and Katie will be the main contact for Isabella County. Kirsten Warren Pale, and Kirsten is the main contact for inpatient crisis residential unit continued stay reviews. Angela Zawicki, and anyone can reach out to me at any time. Again, like I said, feel free to reach out to any member of the UM team if you have a question. UM staff are also cross-trained for inpatient, and eventually Kirsten will be trained to review authorizations for medical necessity. Let's review some of the current authorization routings. Looking at the top arrow, some authorization requests are automatically approved if the request falls within the level of care for the consumer's needs. Please note that the level of care grid is being updated and the process will be a little different. The new level of care will be selected by the clinician on the disposition page of the psychosocial assessment. This will give the clinician the opportunity to override the decision and note if the consumer should be at a higher or lower level of care. There will be more training provided on this topic as we get closer to an implementation date. The second authorization arrow routing process is for when a caseholder is requesting CLS H2015 for 40 or more hours per week, or if there is a request for T2027 overnight health and safety supports. That authorization goes from the caseholder to UM to caseholder supervisor, and then to the caseholder's program director if the authorization request is over $5,000. If the caseholder is requesting any service that requires rate setting, it will go from the caseholder, supervisor, provider network to input the rate, and then to the program director if it is over $5,000. What does centralization of UM mean to me? The new upcoming process with an implementation date of August 30th, 2021. If the caseholder is requesting an authorization for the following high-risk, high-cost services, the authorization will come to Utilization Management for review of medical necessity. Those codes include H2015, CLS. Keep in mind, if the request is just for one unit of H2015, that will now go to UM. T2027, overnight health and safety supports, That code is only to be used for waiver consumers. T1005, respite 15-minute unit code. H0045, respite per diem. That cannot be used for SED waiver and children's waiver. T2036, overnight camp code. That is only to be used for SED waiver consumers. H2014, skill building. UM will only review contracted providers. H2023, support employment. Again, UM will only review contracted providers. INDTR transportation. T2025, fiscal intermediary. We included transportation and fiscal intermediary because they often are associated with CLS authorizations, so we wanted to make sure that those were coming to UM as well. H2016, residential CLS, and T1020, personal care, are unbolded because those are going to transition later to UM. So currently, UM will be focusing on the bolded codes. The new authorization process for the codes listed above will be case holder, utilization management, provider network, if rate setting is needed. Again, centralization of UM is the process of having the high risk, high cost HCPCS codes that we discussed going through a different process for review of medical necessity. If you notice, the authorization process for these codes has changed from the current process in that an authorization request no longer goes to your supervisor or your program director. Program directors will have access to a report regarding the authorizations. The level of care grid authorization requests and the HCPCS code that has not been determined to be a high-risk, high-cost service will maintain the current authorization process. UM is here to support clinical determinations, but we also need the documentation to support the medical necessity of the service. This is when UM would reach out to a case holder and supervisor if there are things missing in the documentation that is required. We will include your supervisor on communications so they can also be a support to you as a clinician. This is not meant to be punitive in any way. Things change, and sometimes it's hard to remember what change we are required to implement. Since this is a new process, the expectation is that we will have some bumps, and I want to encourage back and forth dialogue as we can update the process, but I need to know what is working well and what is not working well. MD-HHS requirement is that adverse benefit determinations are sent out if authorization disposition is not reached within 72 hours for expedited or 14 days for standard requests. UM will not be able to review an authorization until all of the information that is required to determine medical necessity is received. Therefore, case holders will need to ensure that the information is available at the time the authorization is requested. UM will reach out to case holders and supervisors if more information is needed. Adverse benefit determination. If the case holder submits an authorization and documentation is missing, and UM does not get the documentation within the required time frame, we would need the case holder to send an adverse benefit determination stating there is a delay due to medical necessity. If a denial does need to take place for a high-risk, high-cost service after a lot of discussion, UM would send out the adverse benefit determination if it was for an addendum. In terms of a new PCP, because those authorizations haven't been approved, the notice of benefit determination within the plan provides the required notice. Supervisors have the right to appeal a utilization management decision by requesting that a secondary review be completed. If a supervisor does not agree with a UM decision made by the utilization review specialist, the supervisor may request a secondary review be done by the utilization manager in writing via email. The consumer's available documentation will be reviewed, and additional documentation may be requested from the case holder if necessary. If once the utilization manager determination is made and the supervisor continues to dispute the determination, a review may then be done by the deputy director for service for final determination of the decision. So let's talk about what UM staff will be looking for to support medical necessity. Overall, UM will be reviewing the level of care, standardized assessments, clinical assessments, medication reviews, psychiatric evaluations, and IPOS, ensuring they're all consistent and support the care and treatment that the consumer has requested or is receiving. It is an expectation that the psychosocial is current, up to date within the last year, before an authorization request is sent. Please focus on updating the presenting problem and diagnostic summary if there have been changes. UM will be reviewing if the IPOS intervention support section of each goal clearly explains the supports and services that natural supports, community supports, and each provider are responsible to provide. The IPOS intervention section must include all the components for amount, scope, and duration for all authorized requested services. If not, UM will ask the caseholder to update the information. If a consumer is receiving or authorized for personal care, UM will look to ensure a current script is on file in the chart. If a consumer has an IDD diagnosis, UM will look to ensure there is documentation in the chart to support that the IDD diagnosis manifested before the age of 22 years old. UM will look to see if the documentation in the chart is potentially restrictive or intrusive, and clarify with the caseholder if we are not sure. UM would not be able to approve an authorization for medical necessity if there was something intrusive or restrictive in a plan without having BTC's written approval. UM will look for things such as one-to-one staffing, two-to-one staffing, or line of sight. If one-to-one is listed in the plan, please update that to shared versus non-shared, as one-to-one is an alert for BTC as potentially being restrictive. The intent for UM to look for these elements in a plan is to ensure we have the proper documentation, prevent any confusion, or possibly reduce the need for future addendums. When it comes to authorizations, please make sure to note if the consumer has a roommate or not, and if there is the possibility that services could be shared. UM will also be monitoring for over and underutilization of services. If a consumer is utilizing their services less than authorized, or historically is utilizing less than authorized, please review if the services are still medically necessary before submitting the authorization. Example, if a consumer historically only uses 50 hours of CLS per week, but 85 hours are consistently approved from year to year, and the consumer is doing well, then it would be determined that the 50 hours per week meets medical necessity, and the 50 hours should be what is requested going forward. If something happens in the future, hours can be added if they are medically necessary. If a consumer is utilizing more services than authorized, a discussion must be held with the consumer and provider or SD arrangement holder to bring services back in line with what is authorized as medically necessary, or determine if an increase is medically necessary. The Authorization Utilization Report on the Caseholder and Supervisor Dashboard provides additional information relating to a consumer and the percentage they are over or underutilizing an authorization or service. This would be an excellent resource to review prior to meeting with the consumer family guardian to discuss medical necessity and what services would be clinically appropriate to authorize. If you do not know how to run that report, please reach out to the quality department to Kara or Shanti. UM will review if the minimum amount of services requested is being provided, as it is a requirement that CMH is providing the minimum amount of services authorized in a plan. UM will also be reviewing if the range of units in an authorization are appropriate to accurately reflect the needs of the individual and what services they are receiving, and small enough to account for reasonable, typically occurring fluctuations in service. Example, for CLS, a small range would be 200 units to 240 units per week. If a CLS request listed 1 unit to 220 units per week, UM would ask you to update the range. UM will review waiver consumers to ensure that the service request follows the Medicaid provider manual guidance and limitations for those services. For CLS requests, UM will review if there is an approval or denial from DHHS for home help in the chart. If not, please remember to limit your CLS requests to no longer than 90 days while we wait for a home help assessment to be completed. UM will review if a CLS assessment tool was completed either in the psychosocial or standalone. The CLS assessment must be current, up to date within the last year. UM will look to see if the CLS assessment recommended hours match the authorization request. If there is a discrepancy in the number of hours requested versus the recommended CLS hours per week, there must be an explanation in the CLS assessment under the question medical necessity, reason if outside of the CLS assessment determination, as to why this is different than what is being requested to be authorized. We ask for this information because sometimes consumers need more CLS and sometimes they need less, and this documentation helps to uphold medical necessity. UM staff will be looking to see if the CLS request includes overnight hours during a consumer's normal sleep time and ensure that the hours are transitioned by 9/30/2021 to one of the new codes, H2015 UJ for non-waiver consumers or T2027 overnight health and safety supports for waiver consumers. Intervention examples of the required information for each service can be found in the CM Onboarding Handbook. How can UM staff provide support to me? UM staff can help by being a resource. If you ask us a question and we do not give you a clear answer, we need to know that, because what may be clear to us is not to you. A resource is only as good as it is helpful. We intend to provide every county with an assigned URS staff that they can get to know and build trust with and can consult with about cases and documenting medical necessity. That person may not always be the one to review the authorizations for that county, as we have a timeline to meet for completing these reviews. UM staff can attend staff meetings to provide support as needed. UM will continue to work on building a partnership with clinicians. UM will provide training to caseholders and supervisors before the high-risk, high-cost authorizations are sent to UM for medical necessity reviews. If your team has questions from today, we can provide smaller trainings, and we can also provide trainings on patterns that we are seeing where teams may be struggling. Provide tools and resources to supervisors and caseholders to help them. Provide a set time each month that caseholders and our supervisors can drop in and review charts or topics of interest and answer questions. Ensuring that the UM sections of the Caseholder Onboarding Handbook is continually updated with solid information that caseholders can use. I can share updates on things that are happening at Mission, MDHHS, technical assistance updates, upcoming HCPC code changes, and let you all know when I am challenging a change. I am open to any and all suggestions. I may not be able to implement them all, and they may not all fall under UM, but it is always worth a discussion. Once the new process has started, I'm also happy to circle back around and discuss what may be going well and what may need to be changed. We have an Excel sheet calculating home help and max allowable hours. This will automatically calculate the home help and other hours of services to ensure that you do not go over 24/7. CLS Intervention Template Guide. You do not have to use it, but it contains required information and is the easiest way to help support medical necessity in an IPOS, and it ensures that your plan is clear and concise. Another Excel sheet titled Weekly Schedule. This will auto-calculate a person's schedule for you. It is not required, but it is a very helpful tool. It can be used with a consumer or family to help determine what type of support is provided throughout the day. It gives you a clear picture of someone's schedule. The Caseholder Onboarding Handbook covers all the topics in detail that were discussed today. It will also be kept up to date. URS Medical Necessity Review Tool that URS staff will use to help them determine medical necessity. The quality department created caseholder trainings titled Consumer Outcomes and Utilization Monitoring, Collaborative Individual Plan of Service, and Medical Necessity. All of these forms and trainings will be available on the agency intranet, and if you have any questions on how to use the forms, please reach out to UM team for help. If for any reason you are giving conflicting information, please reach out to me so we can review if there was a change that was not shared and ensure that we are all on the same page. It's important that we work as a team to review where the breakdown in the process may have occurred. Again, this process is constant quality improvement. Teamwork. I think we can all relate to this meme on some days. A great example of how UM can help a caseholder is when you know that a consumer needs a certain level of service, but the medical necessity is not clearly documented, or you're having difficulty trying to document the medical necessity for that consumer. UM can give you suggestions on where and how to get that information so that you do not feel alone in this process. Please know a lot of thought has gone into this process change, but we are only human, so we may have missed something. So I want to make sure that we keep the lines of communication open at all times, even if it is for a tough discussion. I want to thank you all for the quality work that you have continued to do and your commitment and fortitude to the people that we serve. We have been going through historic times, and you have all risen to the challenge. Just so that you know, we are keeping track of all the questions from each training and typing up a frequently asked questions sheet to go along with the recorded presentation and all the forms that we discussed today. This will be sent out to your supervisor sometimes after the last training on 7/29/2021. Please let me know if you have any questions or suggestions from what you heard today.